Start, please.
Good evening, everyone. Myself, Dr. Kanchan Durugkar. We are here with our another Facebook live session, and our today's Facebook live session is about freedom from endometriosis. So we are having a discussion on freedom from infertility, and in this our session today is about freedom from endometriosis. So, what is the incidence of endometriosis, or how much percentage of the women's are affected with endometriosis? So, around the incidence of endometriosis is around 10 to 15%. Around 150 to 200 million of ladies in the reproductive age are affected with endometriosis. So, why such increasing cases of endometriosis is seen in today's day-to-day life? So it is because of the early age of menarche, when the first periods the girl is having. Earlier, the age when the girl used to have first period used to be 15 years, 16 years. Now it has come down to 12 years, 13 years, 12 years, even 10 years also. So the early age of menarche, then late age of pregnancy, delaying of pregnancy. So there are more cycles of menstruation, and other environmental factors are also there, and more the endometriosis is getting diagnosed. So that's why the incidence, we can say, is increasing now. Why there is a delay? Again, there is a, though the incidence is increasing, there is a delay in diagnosis. So why there is a delay in diagnosis? It is because of the non-specific symptoms. It is because of the some no there is no some blood test, like, and there is lack of awareness, and there is a some social stigma also to it. Now, what how do we diagnose, or how do we diagnose a particular lady as having endometriosis? Either we can do is the transvaginal ultrasound, but yes, in the unmarried girl, unmarried women's, we have to do is the trans abdominal ultrasound. And in this we can come across is the ovarian cyst maybe, or some infiltrations or some lesions we can come across. And we can also, if at all the deep infiltration is not uh, diagnosed on USG, then we can go ahead with MRI also, where we can again have the detailed study of whatever the diagnosis is, and we can have a confirmed diagnosis of endometriosis. So uh, for the diagnosis of endometriosis, we have is the first and foremost is the transvaginal sonography, trans abdominal for yes, and then MRI for the confirmation if at all any doubt is there. But most of the time with transvaginal ultrasound only we can diagnose most of the cases. Now, this is how the US is the USG picture of endometrioma. There is a typical, this is the typical picture of ovary, where we can see a ground glass opacity. It is called as a ground glass because it is a homogeneous, it's a plain opacity in the ovary, or we can say it is a endometrium, it is a cyst like structure, and it is a ground glass opacity which we can see on the USG. Now, uh, other modalities of diagnosis is laparoscopy. Yes, laparoscopy is said to be gold standard for endometriosis, but it is not that the every patient for the diagnosis needs to undergo laparoscopy, because yes, laparoscopy is an invasive procedure, and if at all the patient is definitely getting benefited with laparoscopy, then and then only the patient with endometriosis should be posted for laparoscopy. Earlier the thoughts were like, endometriosis is diagnosed, then go ahead with the cystectomy, endometrioma removal, laparoscopy. That is a gold standard. But in today's practice, in the today's IVF era, we have to stratify. We have to plan according to the patient's need, patient's age, patient's requirement. That whether the, before putting a scope, before putting a single incision on patient's abdomen, we need to think twice whether we are doing good for the patients by doing laparoscopy of that patient, whether we are doing help in the patient. So surgery has to be very, very sensitively handled in the patients, because patient may land up in 2 3 surgeries for endometrioma removal, and they may not get free from the pain, and they may not have the improvement in their quality of life, so surgery is laparoscopy, though it is a gold standard for diagnosis, it is said, but it has to be stratified which patient we will undergo with laparoscopy. Now, in this laparoscopy we can see various findings, like in these pictures we can see there can be adhesions, there can be endometriotic spot, which we call in our medical language, like powder burn appearance, or white spots, or some other jelly like form can be there. So these spots or adhesions or deposits, we say, are the signs of endometriosis. And and from this we can grade also. I will come to that we can grade the endometriosis also accordingly, and then we can or we can stage it, and then according to the stage of the endometriosis we can plan for the patient, that if this stage is there, then what should be the plan. And if it is an earlier stage, and if it is a milder stage of disease, then what should be the plan for that patient. And if it is an advanced stage of disease, then what can be the treatment options. Then there are different staging, there are various consensus, we can say, or there are various commit societies which have put forward various staging systems, so that we can grade them. Why to grade them? Why we want to know whether it is mild, moderate, severe? Why we want this staging system? So this staging system came because we need to have the line of management for these patients. The age of the patient, whether the patient is seeking for fertility, or whether the patient is having pain as a main symptom. So accordingly, and what is the stage of the disease. So whether it is an advanced disease or it is a milder form of disease. So accordingly, the stages of endometriosis, these are the different classification where we can see that the endometrioma is if it is in superficial, or it is and how much is the lesion size. According to that we score the we give the scoring system, and whether it is involving the peritoneum is a area behind ovaries, and in the ovary how much is the size of lesion, then in the uterosacral and other areas, whether it has spread or not. And accordingly we have the scoring, or we can grade, or we can say whether it is milder or moderate or severe type of disease. So these are the different staging system for endometriosis that are put forward by different fertility societies that we have. Now, we also have one endometriosis fertility index. In this also, according to laparoscopy diagnosis, or according to USG or laparoscopy, we find the lesions, and we then again stage it. And accordingly, we take out the score, or we can say the fertility index of that endometriosis patient. And if the score is on the higher side, the fertility chances are more. If it is on the lower side, the fertility chances are less. As we can see in this chart, that when the this EFI score is less in that patients, the fertility chances or the pregnancy rate is low. When the EFI is increasing, EFI is endometriosis fertility index. And how it is calculated? It is calculated by taking into account how much is the spread, how much is this lesion size, and where it is seen, or whichever the area it is seen. So accordingly, the fertility index is calculated, and accordingly, the patient's uh, score is calculated, and then the uh, plan of treatment can also be uh, uh, taken into account. Now, there is medical therapy. So we have medical therapy for endometriosis, we have surgical therapy. Now, what are the medical therapy? NSAIDs for pain relief, then combined oral contraceptive, danazol, which it is an age-old treatment, but it is not generally used nowadays because of its side effects of virilization, hirsutism. Then we have a novel progesterone, that is Dinogest, which has proven to be effective in the patients with superficial and deep endometriosis for relief of the pain. Then we have GnRH agonist also. GnRH agonist in the form of injectables. They are given in the form of monthly basis, and then GnRH agonist basically causes menopause-like situation, and where the ovulation is not there, ovary is shrunken, so the patient will not have ovulation, not have menstruation, and that will relieve her endometrioma inflammation, and ovulation is also suppressed. So this is how the GnRH agonist injections work. And we have oral GnRH antagonist also, but they are not routinely used like icabolics and linzolix. They are the oral GnRH antagonists which can be used, but they are not generally routinely used. Now, going ahead, we have to stratify whether the patients uh, need the surgery, or the patients. So we need to see the risk of going for surgery for endometrioma prior to IVF, or risk of IVF prior to surgery. Now this is a very very important decision in the patients with endometriosis, that we need to take whenever, or we have to discuss it with patient. See, so in endometrioma surgery, it is very, very skill dependent surgery. Only a proper skilled surgeon should actually, as a moral responsibility of a laparoscopic surgeon, also the doctor who is skilled enough should only take the endometrioma surgery, because if at all there is a damage to the ovary, there is a definite risk of damaging the ovarian reserve, and the ovarian reserve will come down to such a low level that even then the other treatments like IUI or IVF options become difficult after the endometrioma removal. Then cost of the surgery, post-operative complications can be there, and again the impact on ovarian reserve can be there. That can be an incomplete surgery also, so patient can come in within a 6 month or within 1 year again with same endometrioma. So the recurrence is very very common in the patients with endometrioma, and yes, it may delay ART. And what are the IVF related problems? If at all we go with IVF, then it can cause progression of disease, but it is not proven. See, IVF causing progression of disease is not proven. Okay. And then difficult oocyte retrieval, yes, it is a problem if the patient's having severe. This is the problem in the patient with severe grade of endometriosis, like stage 3, stage 4 endometriosis. In these patients, the ovaries are occupied all over with endometrioma. In these patients, the oocyte retrieval become difficult. There is a risk of cycle cancellation. Then there can be a risk of follicular fluid contamination, endometrioma infection, and malignancy is very very rare again, and pregnancy related complication can be there. Now this is the picture laparoscopically we see of the frozen pelvis. Here all the anatomy is disturbed. We cannot say this is the uterus, this is the ovary. So this is the picture of grade 3, grade 4, I will say, of endometriosis, where the anatomy is disturbed. So in these patients, IVF is again the treatment option for grade 3, grade 4 endometriosis. Now, hysterectomy is an option for the patient who has completed. So, we are discussing today is freedom from endometriosis. So, freedom from endometriosis, hysterectomy is a definitive surgery, but it is not for the patient, for the childbearing age group. This disease is of childbearing age group. This disease is affecting the women's under the age of 35. So again, it is a childbearing age group, but for them, unfortunately, the definitive surgery is hysterectomy with oophorectomy, where we have to remove all the tubes and ovaries and uterus, but it is not for the patient who are seeking fertility, of course. Now, See, these are the some committee opinions that how should we go ahead with the treatment. So patient's age, then her infertility duration, then her pain level of pain, her endometriosis stage, all need to be assessed, and then we need to see whether we have to go with laparoscopy or we have to go with other treatment. All the patients with endometriosis will not need IVF. So if the patient is young, her ovarian reserve is good, she may have a good ovarian reserve and she may be ovulating along with endometrioma. So in these patients, either we can go with IUI or ovulation study IUI. The patient, we have seen the patient with endometrioma conceiving with IUI also, with her own eggs, with her own IUI ovulation. We have seen good ovulation in this. Yes, sometimes there is a problem in ovulation in these patients also. Sometimes they may have luteinized unruptured follicles, they may have, or they may have some quality egg quality issue also. But these patients need the better, better counseling, so that they can uh, have the decision of, better than going for expectant management. If they are diagnosed early only before marriage also, some females may have been known that they are having endometrioma, so they should be counseled that they may have fertility issue. So in these patients, even the IUI can be a treatment option if their age is okay, they're, less than 32, and their egg reserve is okay, then, and their tubes are okay, tubes are patent, then in these patients we can go ahead with IUI also, and we have got the pregnancies with IUI also. But if the patient is older, if she's more than 35, her egg reserve has diminished, and we can see that the ovaries are, if the bilateral endometrioma is there, her egg reserve or AMH, we will say, has depleted, then in those patients, we need to, have the quick decisions, and these are the patients who will need IVF, and IVF need to be considered seriously in these patients. Then uh, the stage 4 patients, conservative surgery in the form of laparoscopy is beneficial, but again we need to stratify. And in these patients with previous failed IVF, also laparoscopy need to be considered. But yes, in the patients who have very low egg reserve, or who have the history of empty eggs or empty follicles in the previous IVF, these patients may need, donor eggs. So these are the patients in whom we have got follicles, but they were empty, or they have very low egg reserve. So in these patients, we need to take the donor uh, embryos, or if at all we don't have any follicles only, we don't have any AFCs, in those patients also, where the ovarian reserve is very very less, all the ovary has been occupied by endometrioma. So we have come across with these patients also, where the ovary is completely occupied by endometrioma bilaterally, where we cannot see any eggs. So in these patients, donor oocyte adoption can become a treatment option, or is the treatment option for those patients, and they can have a healthy pregnancy with the donor oocyte adoption plan. Now, we will come to the fertility preservation methods. So, fertility awareness is increasing in our society. So, fertility, if the patient is before marriage, also some women may be knowing that she is having endometriosis, and she may have the fertility issues when if she will be planning for the pregnancy. So, in these patients, what are the method for fertility preservation? So, in these patients, oocyte vitrification. What is oocyte vitrification? We retrieve the egg, we stimulate the patient's ovary when she is having endometrioma itself, but her age is okay at that time. So we stimulate her ovary, we retrieve all the eggs, and we freeze all the eggs. And if the patient is married, she's not planning for pregnancy, we can retrieve eggs, we can do the ICSI, we can cryopreserve her embryo also. So either oocyte vitrification or embryo vitrification, both can be offered to the patient, and it has given a good pregnancy rate, and the patient can plan her pregnancy also, even with the endometriosis also. But yes, sometimes she may have to face with the ovarian less ovarian reserve. Yes, definitely we cannot deny that in the patients with an endometriosis. Egg quality may be handled, but it is not in the all cases. So, fertility preservation options can be in the form of oocyte or embryo, or even we have a recent technology of ovarian tissue cryopreservation also. Like if the patient is undergoing oophorectomy during the laparoscopy, So in this, the ovarian tissue also can be cryopreserved, which can further be used for egg retrieval, and then from that we can get embryo, and which can give the pregnancy. We have some case reports also on that we have done the ovarian tissue cryopreservation, and from that also we have got the live births. So these are the different newer technologies of fertility preservation, where we can either preserve the ladies or women's oocyte is the egg or embryo if she is married, and otherwise ovarian tissue also can be preserved. So these are the recent studies which I wanted to put forward. Now, if the patient with endometriosis get pregnant, what are the problems or what are the difficulties she may face when she is uh, going through her obstetric, obstetric duration, or ANC period, I will say. So the endometriosis patient may have, more chances of preterm delivery, small for gestation age babies. Then they may have some high chances of cesarean section. They may have high chances of, placenta previa. Placenta previa is a situation where the placenta is low lying, it is so they that may cause, bleeding during the antenatal period, and there is an increased risk of, again, hypertension, that is called preeclampsia in medical language, that is BP is raised during pregnancy. That can also be seen more commonly with endometriosis. And again, the NICU admission because of the preterm delivery and all, the lady may the baby who is born is low birth weight, and the baby may need NICU admission. So these are the obstetric problems which the endometriosis patient may have. So this was the different discussion we did today. Then the routine discussion we have normally for the endometriosis, like what is the symptom of endometriosis, what is the incidence of endometriosis, what are the symptoms of endometriosis, and what are the causes of endometriosis, or what are the theories behind endometriosis. So we had some uh, different discussion today, where we discussed about, what are the options for the patients with different stages, how we stage medically, how we stage the patient, what are the different options for the patients, how the fertility can be preserved in these patients, and how the patient can achieve pregnancy. And yes, the patient who are unmarried, who are aware that they are having endometriosis, they may face the fertility issues in the future, how their fertility can be preserved. These all things we discussed today. So I think endometriosis is a vast topic, and the today topic was freedom from endometriosis. So I think the freedom from endometriosis will be if the patient is getting proper counseling, patient is directed toward a proper specialist, where she is guided properly about the best possible option that she have, whether she is suffering from pain from endometriosis, or she is struggling with fertility because of endometriosis. So what is her problem, what is the women's need? Accordingly we need to stratify, and the patient getting the proper best treatment for her endometriosis will be the freedom from endometriosis, I would say. And yes, it is a difficult situation for those who are facing it, definitely. it is a painful situation. The symptoms we know, the dyspareunia, I mean painful, painful intercourse, then dysmenorrhea, that is they're having pain during periods, and again they're struggling with fertility. So this, and they have undergone one or two laparoscopies we see. So difficult situation is there, but it is not that it is uh, intractable. We can achieve over it. We can achieve pregnancy over it. We have seen the patients with endometriomas with having with having good live birth. Even the patients with endometrioma having conceived with IUI, even the patients with endometrioma conceiving with IVF with their own eggs, or maybe sometime donor eggs if at all required, but they can achieve pregnancy and they can have a live healthy baby also. So I best luck all the patients who are struggling there with endometriosis, and yes, you are fighter and you can achieve pregnancy for sure. Thank you very much. If at all any questions are there, they are welcome. Okay, so I would like to end my Facebook Live session. If at all any questions are there, our helpline number are flashing on your screen. If at all physical consultation is required, we have our center at Oasis Fertility, Wakad, Pune, and also at Kharadi. So, uh, any discussions, we are welcome. Thank you all. Thank you, viewers. Thank you so much.